AM 1220, KHTS, HometownStation.com. I am T, normally with you during your drive time Monday through Friday, but today I get to be part of the Providence Holy Cross Hour, and today I'm speaking with Dr. Antebi, who's an orthopedic surgeon, and we're going to talk a little bit about hip replacements. How long has, again, I mentioned earlier, you came to this field, when you started medical school, you didn't really maybe know what you wanted to do specifically, but you'd had sort of that moment where you met a doctor who kind of sparked an additional interest. How did you come to doing, because hip replacement is something that is a specialty of yours. How did you come to that?
Yeah, so during medical school, you choose very early that, you're either going to be an operating doctor or a surgeon or not a surgeon. So I chose to do surgery. And then, within a few rotations, you get to meet an orthopedic surgeon and you do general surgery and this type of, and then orthopedics just grabbed me. And if it wasn't for this field, I would not be in medicine. I mean, it's something that really, I get a lot of fulfillment from. So I did an orthopedic residency for 5 years, and then I did a trauma fellowship for a year. So most orthopedic surgeons, most general orthopedic surgeons come out of training, they do hip and knee replacements. One of the things that I offer is it's called the anterior approach. And the anterior approach hip replacement is something that I started doing approximately 7 years ago. It does require some specialized equipment in addition to a specialized table that the hospital, as Holy Cross did, Providence did buy the table for me particularly to be able to do these replacements at the hospital. So in order to do the procedure, you have to be laying on a special table. We have to position your leg in a certain way in order to get the surgery done. Now, this surgery, the anterior in lay terms, means front. So we go in from the front. Most surgeons do the replacement either from the side or from the back. If you go from the back, you're usually cutting through the gluteus maximus, and most people know that as the butt muscle.
Well, only if you're cutting some off. That would be totally okay.
Yeah, exactly,
but now but that's one of the biggest muscles in the body,
isn't it? It is the biggest muscle in the body, and by cutting through that muscle, just imagine you are, immobilizing that muscle. You're traumatizing it, having to put the hip in, and traditionally most surgeries that are done that way, they do okay. It takes them a little bit longer to recuperate from. Sometimes they can have a limp. And the biggest risk is dislocation. So because you're going from the back and you're violating all the muscles, it makes the hip a little weaker. And if the components are not positioned perfectly, the hip can dislocate.
This is not optimum. We don't like these things.
Exactly right. So, and even as when I was starting my practice for the first 4 years, that's what I did, the posterior approach. And most of my patients did okay, but I've had a few dislocations. I'm like, there's got to be a better way. So I got some training with some local vendors and local companies and started to do the anterior approach. And it took some specialized training. It required the hospitals that I go to purchase this particular table, get these necessary equipment for me to do this. So now people are getting up quicker, smaller incision from the front, about 3 to 3.5 inches, and much less pain. And we're not cutting any muscle at all. I move muscle out of the way, but I'm not cutting any muscle. The muscle gets moved out of the way. Within 2 minutes, I'm in the hip joint, and in less than an hour, you get yourself a new hip replacement.
This has to be overall, just for most people, I think when you go to do your research and you really need to shop when you're looking to do something like this just seems like a no-brainer, the kind of thing you want.
There's more than one way to skin a cat. And the way, by doing this type of approach, the anterior approach, in my opinion, it's just the way to do it. But you have to understand that this has been popularized for the last 5 or 6, 7 years, and some surgeons have actually tried it. The learning curve is very steep.
Is it?
It's more difficult to do because most surgeons who did their training learned it the other way. And then to kind of teach a old dog new tricks, it's more difficult. But since I was only 4 or 5 years out of training, I'm like, I'm going to do this. And
you became the Michael Jordan of this procedure. As where other doctors will do it, they don't have the same.
Yeah, I've done over 1,000 of these hips already. From what I understand, I'm the only orthopedic surgeon who does this in the Antelope Valley, Santa Clarita Valley, and even in the whole Mission Hills area. So nobody does it here in the whole Santa Clarita Valley.
And this success rate is across the board, whether you're a young person. I had a cousin who, at a very, very young age, had a pituitary tumor, and the steroids that he took, he ended up having to have a total hip replacement.
Avascular necrosis.
Absolutely.
Yes.
And so young patient, old patient, for the most part, this is the most successful way
Yes,
to do
and
hip replacement.
I do all comers, and mostly virgin hips, meaning nobody's who've had previous hip replacements. I don't do redos of hips from the front, but if it's a hip that's never been necessarily operated on, it's arthritic from a previous trauma or avascular necrosis from the steroid use, then yes, it would go from the front.
And so again, you're saying even the fact that you are an expert in your field, you also have to do the procedure at a hospital that that not every place has this particular table.
Not every place has it because not every surgeon is doing them, but because I do go to various hospitals, all of the hospitals that I go to now have the table. So I'm able to do it at Henry Mayo or Holy Cross. I operate at 2 hospitals in the Antelope Valley, which have it as well. And, for example, yesterday I did 3 hip replacements. One of the people that I did the hip replacement is a 38-year-old gentleman, and this gentleman was born with bad hips. So people can have a condition called hip dysplasia, kind of like animals do, and humans get it too. It's something that is developmental. It's something that you're kind of born with, and if it's a severe case, then your hip is going to wear out at a very, very early age. If it's something that is not severe, then it'll probably wear out in your 50s or 60s. But this gentleman basically needs both of his hip. We just did the first one yesterday.
Now, I know once upon a time, hips had a shelf life. Does this anterior because it used to be metal, I believe.
Right,
now,
so a lot of, back at 3 or 4 years ago, a lot of surgeons are using metal on metal. I don't use metal on metal anymore. On younger patients, actually most of my patients, I use a ceramic head with a polyethylene. The polyethylene, which is the plastic liner that we put in, is much better today. It's oxidized with vitamin E and makes it a lot better. The components have definitely gotten better, absolutely.
It's something like Barbie probably has in her
Yeah,
hip if we were
exactly.
to take her apart. And people who have, again, I want to talk a little bit about the idea that you don't redo hips that have been done. What's the longevity of the hip that you put in now? Is there
So this is the analogy that I give patients. So if for example, this 38-year-old who owns his own sign company in the Antelope Valley, he's a very active gentleman. He's not a guy who's sitting at home watching The Price is Right every day. So he's working. So the more active you are, the less the hip is going to last. Kind of like getting a new tire on a car. And if the tire is put in well and it's well balanced, it'll last you a long time. But if you're putting 30,000 miles a year, it's not going to last as long. So I would say the younger person who's getting a hip replacement, God forbid, it's going to last probably about 10 to 15 years. The person who's in their 60s, 70s, and 80s, they'll probably, last forever.
All right, we'll talk a little bit more about this. Again, we're talking with Dr. Antebi from Providence Holy Cross, orthopedic surgeon here on the Providence Holy Cross Hour. We'll be back in a moment. AM 1220 KHTS, your hometown station. AM 1220 KHTS, hometownstation.com. I am T, normally with you Monday through Friday, your afternoon tea during your drive time. But today I get the special added bonus to my day to come in for the Providence Holy Cross Hour and talking with Dr. Antebi, who's a board-certified orthopedic trauma surgeon, discussing a little bit about hip replacement, and we discussed anterior hip replacement, which is what you are an expert in. Walk me through the old school again. What happens? Someone comes into just your normal surgeon, and they're being told they're about to have hip replacement. Not everyone does what you do, and again, I called you the Michael Jordan of your field because you're doing something that, one, has, as you said, the learning curve that's very difficult. Two, the fact that not every hospital has the special table for performing this surgery. So let's say a patient goes in to just, first of all, maybe someone who's not a candidate for the anterior, but walk me through what a traditional hip surgery replacement looks like.
Sure. So most patients or most surgeons, what they do, either the lateral or the anterior or the lateral or the posterior approach, that usually requires that the patient during the surgery time, they're on their side. And while they're on the side, the surgeon will make an incision on their side depending on, what they traditionally do. And they would have to cut through those muscles that we talked about before, either the gluteus or the tensor fasciae lata, which is the tendon on the side of the hip. And when that surgery is done, the important part of the surgery is to make sure that the components that are put in the inside of the hip are positioned correctly. If the components are not positioned correctly and the person moves their hip a certain way, they're taught after surgery, don't move your leg this way, don't move your leg that way, don't bend over more than 45 degrees. That can cause the hip and the pelvis to shift and cause the ball and the socket to dislocate.
So then this comes with its very own risk, just having the surgery in this manner. And in post-surgical, when you're recovering from that, is movement, because I know like in knee replacement where they want you to
Absolutely.
move that, is the hip similar in needing that motion?
The hip is very similar. However, because of that particular approach that surgeon did, they are limited as to how they can move the hip because they don't want the hip to dislocate.
So it's sort of a darned if you do, darned if you don't. You need it,
Well,
you
that
need the
provides a lot
movement,
of
but-
anxiety because most of the time surgeons who do that approach, the patients are literally coming out of surgery with a big ugly pillow in between their legs. It's called an abduction pillow to kind of keep the legs spread apart so the patients don't bend their knee and don't twist their hip in a certain way so the hip doesn't pop out of place.
And how long are they in this position, and what's the typical? I know, every patient's different.
Every surgeon's a little different. Some surgeons may say we want you to use the pillow at home for about 4 to 5 weeks.
Wow.
Yeah, some surgeons say, well, don't bend over this and don't do that, for about, a couple of months.
So this recovery time is long. It's extensive.
It's a little bit more extensive, yes. Now, don't get me wrong. If the surgeon does a good job from the posterior approach and they're very comfortable and they get good outcomes, then it's a great surgery.
Well, and for some patients, that's the surgery they need to have.
Yes.
But if you don't have a doctor who can do the other,
That's
then
right.
this is your only option with this particular doctor.
That is correct. That is correct. So going from the front, as I mentioned earlier, we're not cutting any muscle. We're just moving muscle out of the way. The procedure is done through a 3 to 3.5 inch incision, usually under an hour surgery. Very little blood loss. There's no blood transfusions that are necessary
Which
after the
is
surgery.
also important because even being under anesthesia, depending on the age of the patient, I mean, that can be also its own risk in and of itself. So now
Absolutely.
a shorter surgery time, this is already a benefit. So you have your surgery, no pillow?
No pillow.
Oh, yay.
No pillow. So
This
you're
is-
out of bed the same day. You're walking that same day with your walker. We use what we call perimodal perioperative pain protocol. So there's all this cocktail that I put together and inject it into around either the knee or the hip. The anesthesiologist does their job with their block. So there's really hardly any pain afterwards.
So you can get that mobility
Right away with no precautions whatsoever.
And none of that, don't move this way, don't move that way.
There's no precautions whatsoever.
So the surgery time is short. You're up and at 'em pretty much that same day. How long are you expected to stay, or when do you go home?
Most of my patients, 80 to 85% of the patients go home the next day.
See, I'm thinking to myself, I want to stay in the facility because somebody's going to be taking care of me. I don't want to go home. There are dishes to be done.
Right,
So
exactly.
what kind of recovery are we looking at when the patient goes home? What should they be doing or not doing?
Usually what happens is at home, within 3 to 4 days, they're able to shower, wash the wound. They're walking around the house with their walker or cane, whatever they need to get around. And I tell them, once your pain is not that bad and your limp is not that bad, you can get rid of everything. And that usually happens within a couple of weeks, 2 to 3 weeks.
Wow.
Yes.
So the patient, for the most part, is up doing everyday.
Everyday things, exactly right.
And then
I had one patient that I did a few weeks ago, and she was telling me, she's like, yeah, I went to get my she's a woman, she went to get her pedicure done 6 days after surgery. She was driving. I'm like, wow, that's great.
You can't even have this kind of recovery time in cosmetic surgery,
No.
so that's pretty nice to be in and doing that.
So most patients, they do pretty well. I say it all the time. I do a lot of different types of surgeries. And if every patient needed a hip replacement, I would stop doing everything else because I really believe in this procedure. It's a great, great procedure. And again, not every patient that comes into the office is going to need a hip replacement. We do offer injections to the hip as well to try to alleviate pain. So I always try and find other things to try to alleviate pain besides surgery.
How long do you follow that therapeutic method before you say to a patient, you know what, we need to start looking at the alternative? What's that look like?
I usually, by the time patients come to my office for a referral for a hip replacement, they have been ready for a long time. They've been living in pain and they're just tired of it. The person who's been living with hip pain and they just recently got diagnosed with hip arthritis and they just thought maybe it was like a sore muscle, I'll tell them, I'm like, listen, your hip is bad. Your pain may not be that bad because you're still functioning, but eventually you will get there and you will let me know when you're ready. So we can do that injection, buy you some time, come back and see me when you just can't function anymore. You're just in pain every day.
And everyone's pain tolerance is different. So you might have someone come to you who's right away, you know what, I'm having this pain, as where someone else has been ignoring it or just dealing with it on their own. So you have to assess everyone a little bit differently.
That is 1,000% correct. Every patient is different with their pain tolerance. Some people don't even use pain medication. Some people use pain medication. Some people just use Tylenol or Vicodin or whatever it is that they may use. But every patient is different.
All right, we're talking with Dr. Antebi from Providence Holy Cross. We're discussing a little bit about hip replacement and what can be done with various surgical options, etc. This is Providence Holy Cross Hour. We'll be back in just a moment. AM 1220, KHTS, your hometown station.